Now we're recording. Okay, and then the other thing that I wanted to remember is that if you want to meet with me during my office hours and I'm not in here or you can't see me around, my office is up here, kind of next to the family restroom. It's behind a locked door. Most of the other faculty are downstairs where Bryant is at. They just didn't have room, so they kicked out me and Amanda, and we share an office over here. So just know if you are looking for me and you can't find me, you can send me a Canvas message, or the best way might be go check in with Bryant because he can get through to me if I'm somewhere else in the building. But you can't just go to my office like you would to Chuchi or Eileen or somebody else because it's locked. And this floor up here, we don't have an administrator up here. So just want to make sure everybody knows how to access me. If we do plan, if I say, hey, meet me in my office at 10:30 or something like that, if you just go and sit on the little chairs that are out in the hallway here, or just stand in the hallway, or knock on the little door there, I'll come, I know where to meet you at, but when you can actually come to my office. Hopefully that makes sense. Okay, let's get going. Let's talk about urinary. Are we in here? I gotta click in. Okay, so learning outcomes. What do I hope we learn and we talk about or take away from today? We're gonna talk about this predisposing causes, symptoms, lab abnormalities, and treatment of urinary tract infections. We're going to also look at same thing for kidney stones, right? What causes them, what makes them happen, what do we do to treat with them, and then what are also signs and symptoms of cancer of the kidneys. We're not going to talk about this today. We're going to talk about that next week. So I'm going to skip over that. So first, before we get started, I love osmosis videos. I don't know if you guys have seen very many of them, but I think they're really helpful when you're looking at some of the anatomy and things like that. So this one, I don't think is super long. I want to say 4 or 5 minutes, but we're going to watch this quick osmosis video, and then I'm going to kind of reference back to it during the lecture. So let's make sure we got sound. You guys are okay?
With
Oh, hopefully I didn't kick anybody out. You guys still in the Menti? Yay, okay. I love those videos. I think they're so good. I love the visual aspects to them where I can see, especially the cats, right? When we talk about the urinary tract infections, especially when those cats, I've seen them in like in lab results, but it's that picture of like how they form, I feel like really helps me to solidify that. So when we talk about urinary tract infections, I think a lot of times we think of like a bladder infection, but really urinary tract infections is talking about the whole urinary tract. So I was wondering if anybody feels super brave and wouldn't mind matching these structures to where they're at in the body. Yeah, all right, class rep, let's go. And all you have to do is just draw like from the word to where the structures are at. And you can phone a friend too. All right, give her a hand. Bravery wins. No, like that's sweet. So we have two kidneys, right? Most of us, most people are born with two kidneys. Occasionally, you'll find a unicorn that was born with one. And by unicorn, I mean somebody special, person. I don't know what unicorns have for their organs. Um, because you have two kidneys, they each have a ureter. It's a tube that when the kidney collects all the fluid and the waste products, and those go from the kidneys down the ureters, both into your bladder. Then from your bladder, you have your urethra, right? Urethras are very similar in men and women, except for usually the length and where they're located at, right? We talked about how women, right, it's more of a downward or south angle, where men, the urethra kind of, it's longer, right? Where like when you guys done Foley catheters already, right? When you're going to catheterize a male, you always want to make sure you lubricate that catheter longer than you would a female because their urethra structurally is longer. So we want to make sure we've lubricated long enough to make it more comfortable for them. Okay, so I might refer back to some of these structures. So thank you, Brianna, for labeling them for us. So most of the urinary tract, typically, when we look at anything just beyond this urethra, we consider it sterile. So everything above here should be sterile. It shouldn't have bacteria or infection in it. Now at the urethra, we're in contact with the outside world. We have our flora that's all around us. So we might have some bacteria there.
I'm sorry to ask this question. Like with the male, the anatomy's length, how does that respond with the length or not?
Yeah, absolutely.
So I mean, like, I'm gonna check the person before you get started or whatever. But then you might need more if they.
Exactly. If the penis is longer, the urethra is going to be longer, so you need to make sure you're looking more. Yeah, it's a relevant question. So we shouldn't really see bacteria up above this urethra unless there's an issue that's happening. So if we have a urine or a urinary tract infection, it's usually acquired by healthcare, right? It's usually that we've done something, oftentimes catheterization, something that introduces bacteria into this system here. A lot of times, especially if we have fecal incontinence, right? Especially with women, if that's around this urinary opening, with urethra, sometimes it can ascend or bacteria, they move around. They can climb up into the bladder and cause infection. Usually it's caused by E. coli. Where is E. coli usually found? Yeah, in poop, right? In stool. So that makes sense where we have people who are incontinent of stool, why they would be more likely to get an E. coli infection. All right, so risk factors. We talk about who's at risk for UTI. We want to know, we want to be able to identify those patients, right? Just like we talked about the patient who's, urge incontinence. We know they're a high risk of falling because they gotta go. They want to get up and run. So UTI risk factors. Incomplete bladder emptying. There's some people, because of a neurological condition or other reasons, maybe prostate issues, they can't empty their bladder all the way. So that urine, a lot of it sits in the bladder. It doesn't get emptied out. And we know that anything when it's just sitting around for a while tends to get more infected, right? Just like a pond, right? A pond, if you think about a pond of water, it usually has a lot of algae and other things growing. Where if you have a river moving, things are flowing through, you usually don't have a lot of the algae and other things growing in it because it's moving. It doesn't have that time to grow. That kind of makes sense? A little bit? Okay. Contamination in the perineal urethra area. Like we were saying, if you have stool that's around there, or other people just aren't able to get cleaned, you know, they might get contaminated. Instrumentation, what does that mean?
Foreign object inserted?
A foreign object inserted, yes, or catheterization, right? That's usually what we say when we're saying instrumentation. It's a very fancy word of saying there's some sort of instrument or something going up in there. So usually it's putting in a catheter. It could be also from surgery, right? If they do some sort of cystoscopy or bladder surgery, they're using instruments to go in there in the urethra. If they have faulty valves, excuse me, like we saw in that picture, how we have valves, that if your valves aren't working properly, they can let urine go back where it shouldn't really be. That can cause a problem. Previous UTIs. Unfortunately, if you've had one, you're more likely to have it again, right? Female anatomy, because that urethra is shorter, there's like not as long that it needs to travel bacteria to get to. Yeah.
You say about, previous UTI.
Yes.
So if you have a one, can get again?
You are more likely to get it again. Yeah. That's one of those things where there's some breakdown, you know, in your body's protective mechanism. And that means that whatever that breakdown was, that makes you more likely to get it again.
Small dogs get into it all the time.
Yes, anybody can. Yeah, we, in fact, female anatomy, part of that too is, we have it on there, what do we do? But sex, right? We teach our female patients after you have sex, you should avoid. Because if you have any bacteria things that get moved around, we want to flush that out. We often will see, if you work in a clinic somewhere, ladies who get married and go on their honeymoon, you know, they have a lot of sex and they often can get a UTI. And so we look at that because we make sure you know, like, hey, how do you make sure you prevent these UTIs from forming? It's kind of awkward to talk about, right? But when we're nurses and we're taking care of patients, I want to make sure that my awkwardness isn't keeping them from being healthy and doing what they need to do so they can prevent getting a UTI. Aging changes. We talked about how some of that, especially female anatomy with menopause, that can change some of the anatomy. Men, their anatomy can kind of change a little bit too. And then also genital piercings. If you have a genital piercing, you just have an extra thing hanging out down there that will have ability to hold on to some sort of bacteria or bug that makes you more at risk. Now, this isn't saying that these people, other than who already had a UTI, that doesn't mean they're always going to get a UTI. But those are the patients, if you're taking care of them, you want to make sure you're giving good education and good prevention to help them prevent getting UTIs, right? So if you go out in clinical and you're like, oh man, this patient has a big prostate, can't pee very much. I know he just had a catheter put in to empty his bladder and he's had a UTI before. Man, he's a really high risk of having a urinary tract infection. I really want to look at this guy and monitor him. So it gives you good information so you know what to look for. All right, so types of UTI. We say UTI, and like I said, people usually think bladder infection, but that's the whole system is the urinary tract. So we break it down and with these words. So I like to do some word building, right? You can have these on here too. So who can tell me what does itis mean, the suffix? Inflammation, right? Does it say it on there? It does, man. I'm really good at asking questions that I have the answers on here. So if I ever ask a question, no, the answer is probably on the screen. So itis means an inflammation. It can often be an infection, right? So ureth. What do you think? So ureth, I mean, it's on here, right? What is ureth referring to? The urethra, right? So many of these medical terms, if we don't know what they are, what they mean, we can use word building to find out what they are. So urethritis, that's an infection of the urethra. So just the urethra down here. It hasn't actually traveled up to the bladder or gone anywhere else. It's just the urethra. Same thing, we have cystitis, right? We talk about cysts, that's referring to the bladder. We're going to talk about procedures like cystoscopy. That's when there's a scope. Endoscopy is you have a scope that goes in somewhere, a scope that goes into the bladder. Okay. Then we have pyelonephritis. Pyelo is going to be the word that we use a lot for kidney. Okay. So these words are what we look at when we're talking about what type of infection. So urethritis is the urethra. Cystitis is the yep. And nephritis or pyelonephritis is the kidneys. Does that mean you can only have one at a time? Oh, you could have somebody who starts with urethritis and maybe it travels up and they have cystitis with the bladder, and then that travels up to the kidneys. They have pyelonephritis. So you could have somebody that has all of those, which would be miserable, right? Okay, good job with word building. So here's a question for you guys to answer on your computers. The nurse is collecting data on a patient at the doctor's office who has a fever. Which of these findings are indications of a UTI to the nurse? Select all that apply. So you should be able to select multiple answers. Oh, it only lets you do one? Excuse me. Okay, well, answer the one you think is most probable and we'll go over. Excuse me, the correct answers. Okay. Final answers in and there we go. All right, so let's talk about the correct answers. So dysuria, what does dysuria mean? Difficult, painful, difficult, something wrong is happening with the urine. Yes, that's a sign of a UTI. Bye, Amanda, have fun. Is anybody still using the hotspot? Yes. Oh, okay. I will leave it then. Don't have too much fun. Can you bring it to, right? Yes, I will. All right, so urgency, that can be a sign of urinary tract infection. So can frequency, going frequently. Amber colored urine is not actually a sign of a urinary tract infection. What is it a sign of? Dehydration. Now, oftentimes you'll see those things correlate. People with the urinary tract can often be dehydrated, but that amber colored urine is from the dehydration. It's not from the infection. Ammonia smelling urine. I think some people got a little bit tripped up because oftentimes urinary tract infections, the urine might smell foul. And it's such a general term. It's a bad smell, but it's not ammonia smelling. Ammonia smells more often are associated with like liver type issues. So if I smelled liver or sorry, if I smelled ammonia, I wouldn't think infection necessarily. Anybody smelled like infected urine before, somebody who had a UTI? Yeah, it's not a fun smell. It's kind of gross. You're like, oh, this doesn't smell right. Okay, so let's keep moving on. So common signs and symptoms, like we talked about, urgency, frequency, burning. A lot of people say it burns when they pee. That's a sign of that urethritis, right? It's inflammation of that urethra. In older adults, now, like you guys learned last term with our geriatric type care, older adults are fun. They don't always do the usual. They might present differently with everybody else. In fact, when an older adult starts getting confused and something acting just different, one of the first things we do is do a urinary tract or do a urine analysis. Yeah, urine analysis. Thank you. Because oftentimes that's their first sign and symptom of a UTI is confusion or just something being off. So we always want to keep a careful eye on our older adults. With the cystitis, and where is the cystitis at? Bladder. Oftentimes the symptom they're going to have with cystitis is feeling full, feeling pressure, kind of feeling like this pelvic, just discomfort, achy in the belly. That's with the bladder infection. With the pyelonephritis, oftentimes that's where you see more of this pardon me, systemic reactions where they have fever, chills, nausea, some nausea, we'll get to that. And then they also have the costovertebral tenderness. Anybody remember where that's at? Costovertebral tenderness?
It's like flank.
Yeah, if you take your arm and just kind of do this, move on your back, it's kind of just underneath your scapula. It's going down and then over this angle. It's called costovertebral angle. That's where you usually will have pain. So let's say you have a right-sided, or like your kidney on your right side is infected. Where are you going to feel that pain? On your right costovertebral angle. Because remember, you can have an infection of just one or the other kidneys. Won't always have both kidneys being infected. It might just be one side or the other. Jasmine, you had a question?
Oh. Or Jamie.
Oh, Jamie. Oh, sorry, Jasmine. Sorry.
The pyelonephritis, it says infection of the kidney, not inflammation.
They're usually together, right? But yes, pyelonephritis is talking about infection of the kidney, but there's associated inflammation with it. Because of the infection, that process causes inflammation.
There's also just nephritis, and it's inflammation
Of the kidney. Yes. Yeah. Yeah. Good question. So pyelonephritis is infection, but there's usually nephritis
it's the
inflammation. Yeah. All right. So complications, sometimes they can become septic where that infection goes systemically. That can mean they get really sick. You're going to learn more about sepsis next term in MedSurg 3. It can be serious and it can be more common in the older adults, right? Because their signs and symptoms aren't usual. If you have an older adult that already has dementia or Alzheimer's, and they just are acting up a little bit more, we might not know if that's from just regular and might not diagnose the urinary tract infection until it gets farther along. They're harder to diagnose. So data collection. When I say data collection, what does that mean?
labs.
It's like our assessment, right? All those things that we want to do, like we're collecting data from our patients. So we want to know what their predisposing factors are. We already talked about the risk factors. That's what it is. We want to find out what are their risk factors that they might have. Their voiding pattern. What does that mean?
Did they go once?
Yeah, what's their usual pattern, right? Do they normally go every hour and that's their usual? Or do they go every 8 hours, right? That's going to be very, especially if you think about a man with a prostate issue, he might be in there every 15 minutes just trying to go a little bit because he just can't go. Signs and symptoms, right? We talked about all these signs and symptoms. There's also hematuria. I think the video touched on that a little bit because of that inflammation. There might be some blood in the urine, right? Because heme is the word, using word building. Heme means blood, and then that urea is urine. So we always want to inspect urine for volume, color, concentration, cloudiness. Oftentimes our urine that's infected, it's going to be cloudy. It won't be that nice clear color that we want. There might even be sediment or things in it that you will see kind of settle down to the bottom of the collection container, and that foul odor. And then part of our data collection, we also, like I said, we want to look at their labs, look at the urine analysis, look at the urine culture. So when we talk about nursing diagnosis, right, you guys aren't going to be building the care plan, but you're going to be adding to it. You're going to be enacting it out. So you need to know what nursing diagnoses are. So acute pain, impaired urinary elimination, ineffective health maintenance behaviors. I think it's pretty good now, but I think for a while our culture and society didn't want to talk so much about how to wipe. Right? So if we're teaching our ladies, especially how to wipe, what do we teach them?
Front to back.
Right? Front to back. Because we know that stool, if it gets contaminated, we get E. coli infection. And so that might be where we say ineffective health maintenance behaviors. If they aren't wiping front to back, we would want to know. Nursing care. So you as nurses, what are you going to do? Well, if they have an infection, we're going to be ordering the antimicrobials, antibiotics as they're ordered, right? We're not going to order them, but we're going to give them. We might do some pain control, especially with the cystitis, right? That bladder pain. Sometimes heat on the belly can be helpful. There's also some urinary analgesics. There's some medicines that can go in that actually kind of numb that urethra. So if you're having a lot of burning while you're urinating, that medicine can help to numb the urethra so it's less painful. We're going to monitor their symptoms, right? Especially if they're in a long-term care facility or hospital, we're going to ask them, hey, I took care of you yesterday. You said it really burned when you peed. Does it burn as much now? Is it better? Is it worse? We're going to compare from what they had already. And then we're also really going to look at intake and output. We talked a little bit before about our patients with urinary tract infection. They tend to get dehydrated. A lot of that is it's uncomfortable, right? The more full their bladder gets, the more they pee, they might have burning, that pelvic pain. So they don't want to drink. They don't want to go pee. So the more dehydrated they are, the less fluid they have that's flushing out everything. When somebody has some sort of urinary tract infection, it doesn't matter if it's in the kidneys or the bladder, you really want to increase their fluids because you want to flush all of that out of their system. You want to move it through. So teaching antimicrobials. We take it until we start feeling better, or right, all the medicine, right? We hammer that. You'd be so surprised at how many people are like, I felt better. You're like, oh no. No, all of it. We want to increase their fluids. We also want to teach them what are signs and symptoms, right? We think to us, it might seem common sense. Well, of course, if it's burning while you're going to the bathroom or if you have pain, of course, that's probably a sign and symptom. But not everybody, that doesn't always make sense to them. So we want to make sure they understand these are signs and symptoms of urinary tract infection. Make sure you report this if you start having them. And then the prevention, right? Like we talked about women after sex, pee. If you have a piercing that's causing issues, you maybe need to take out your piercing. Make sure we're wiping front to back. All those things that we can do to help prevent the infection. Okay, I think this is a good time to take a little break. How about, what time is it? Class goes till 3? Mostly. How about, you guys want 10 or 15 minutes? 15. Okay, let's take a break and come back at a 1/2 past. More because I need to go to the bathroom. I think the more we talk about urinating, I'm like, oh, I really need to go.
Distraction.
Curl my toes. Okay, I'll see you guys at 1/2 past.
Yeah.
Hard because I'm supposed to build off of that, but my foundation is 3 points not.
I thought the same thing.
Well, now it's a separate thing, like this is
I
the
feel we'll be okay.
system, but yeah, because this feels more foundational and.
She did say like, you guys, like the first MedSurg, like, history, just like general, like, geriatric, like, injuries and stuff like that, nothing like body systems. She said this will build on.
I should have paid more attention in that. That was a hard class. I'm glad I made it, but. Here we are. This stuff
Take it
is so
here.
important. I took it on like, I went to Karen's line.
Yeah, took one
It
on.
was really hard to find though. There's like no room to cheat. It was not working out. I mean, it's better that you did it in person because some programs require you in person.
Oh.
So.
For me, I took, microbiome. In person, that's the only in-person class I took.
The only in person I took was chem, and I had to retake it because I got an E minus. So I took that online and got an A. And then I was like, okay, I'm moving online. I see. This one, I feel like will be like the most relevant. This is really heavy. It all. So we do the body scan to see how much we are receiving. And then if it's above dangerous level, we be sure to ICP them because we don't want what? The whole reason is because if they retain all that urine without the void, they get urinary stasis, which can lead to infection. Hence why we do this. So first we do the scan and then we be sure to get a culture. And we get the culture by doing the clean patch either through the ICP or through a clean renal if it's a man. But then it's hard to get that when they're already incompetent. It makes it hard. Sometimes they put in order to do a BBM for a patient who's like constant, like who's incontinent, but it's like.
I've seen a lot of home health patients when they come out. Swab.
They swab it?
Swab it from the paper. And send it out. They'll get their
Oh,
see if they do have it.
oh, I didn't know that. They could just do it
Yeah,
from.
because I'm like, you know, like, I was like, oh, I'll help you. She's like, can you remove, like, open? the
So
bricks?
it's a dirt or
It's a
soil
soil,
free.
soil,
They go along.
they'll
the
literally just like push
genitals
that, no, the brief itself, they'll push down on the brief,
to get some fluid.
yeah. It's interesting, huh? Cause I'm
Do
like,
they do that at the hospital?
that one I don't, like, I don't, like, have to really, like, make it possible.
That's what makes your background so interesting. And it was from. I don't want to do it. And then come back at me.
But it's to get like a clean bench, and like sometimes they'll have or somebody to get.
They do the intermittent catheterization.
It could be very complicated.
I saw one of my nurses, they were talking about it and they're like, how did you get the UA? And I was like, well, they got it because they did the intermittent patch to get the fresh.
Yeah.
And she's like, oh. Then I was like, it's okay. It's okay.
But sometimes it is hard. Everybody.
Yeah.
Not everybody's anatomy is the same.
Yeah.
Older person, it's harder. Like, I'm talking about like, when I'm helping them, like trying to insert the cap, it's. When I'm watching them, I'm like, right, are you good? Like, I'm trying to hold, he's trying to hold like a flexion, it's like a headband flexion. See, because it's hard. Because he,
But you're doing it.
no, I'm holding, I'm helping,
Oh, but you're not inserting.
no.
Oh, I was like, oh.
That's crazy. No, I watched that.
Playgrounds
No, I watched.
in your home.
I watched it. I guess I like access. It's very interesting. I was like, how do you, because he went here back in 2019. He graduated from here.
Was he up there?
But he's now right now, he's in our program.
Which one?
I don't know. Yeah. It's further up north. Highland,
Highlight?
maybe Highland? Or Red, whatever, it's somewhere right there.
Okay.
But he said like, oh, out of here, that's very similar to what. And from there, that's where you build your foundation. Don't expect like to go out there, you know. You're still gonna, they're still gonna teach you very in depth, like the skills and stuff. Because for home, they do a lot of stuff.
It's just, I don't know if I should go down my specialty first, or if I should do a general.
For us, we've been working on different worlds. They work more outpatient. I've seen outpatient.
I do not want to work at a clinic
Yeah, more.
at first, because I feel like that might like keep me close. You
Like how
know,
you-
because at the outpatient clinics, they do primary, like, when you do the sniff, they do that stuff where it's like the question, I mean, we do that at the hospital too, but it's less skill based in my opinion.
Yeah, I could see that, because you, because, outpatient is just more so like they're there, they're leaving. It's not someone to take care of for like first days and stuff like that, so.
I feel like I'm the type who needs things to be hard for me to get it.
Hard-headed?
You're mean. You're mean.
Yeah.
That, it's an assumption that's been proven, but
Like a challenge, right?
You like a challenge. That's what I was telling my brother.
is that what?
Cause my brother's like, I've noticed a trend with my brother. I'm telling him, I'm like, you should do this, because I've already done that. He's like, I'll do it this way. I was like, okay, in my head, I'm like, he needs to get a breaking point. He was like, oh, my brother's right, I need to. He needs to experience it for himself. Take it.
But I hate it, you know, because I feel like I'm doing myself a weird injustice. Because I make things harder for myself in all areas of my life. For some reason, I feel like I'm like my biggest enemy.
Do you think I'm just gonna like sit down and be like?
Just think about it. You build care. You learn more from yourself.
And then we open to, just like it was like a small.
I'm still making dumb mistakes out there.
Like.
I shouldn't have done that manual blood.
You did fine. You probably was like, wow, she's practicing this early. She's a go-getter. Right?
My mom was like, "How is in your?"
No.
And I was like,
Okay, that's a little too much.
all he said was, "It's okay." So it's red flag.
I probably should be back now.
So like grab my arm, and he was like, it was nighttime, and I tried to change him, but he got really aggressive. He became aggressive so much to the point where he took his CPAP off. So I called him for help. You know, my ex-friend was like, I took the back and everything. Like, let's just get a
No, no, not for you, honey. Step aside.
Well, he's a man, so I was like. And then like, you know, we were fine. No, she was at the computer and he was like playing with dice or something. I
You're
was
like,
That was.
you're like,
Isn't it?
she's like, hey,
You make me laugh so hard.
He came to the room to be like, "What?" And I was like,
you should just kept looking over her.
At the door, like, no one.
Yeah, like, people-
Walk in.
yeah, I was jealous of her because they're talking all the time in front of me, and I'll be charting and I'll be like,
Kind of like.
then I'll be leaving. But anyway, he called me, but like that patient kept grabbing my arm, and then I got bruised. And I was just like shaking the whole time, and he saw that, but he never asked me if I was okay. Like, so I was like, is that a red flag? He didn't even ask.
You might not be the type that.
Oh.
These twins. But if he's a nurse, he should be pretty.
He should be observant.
Oh,
You
right.
should see how I was kind of like. So I was like in my head, honestly, I was trying to make it a little exaggerated.
You're all doing, you're like, somebody just open the front.
Like, well, let me give her. Let me let her simmer down before I see if she's okay.
You're all.
Honestly, I was trying to look like my uncle. I was like, is he
And
gonna?
then. Yeah.
I feel like, hello.
Hello, is he gonna?
I need to. Please, my arms.
No,
You
literally,
don't wrap it up with the bandage.
no, literally, I sleep up and the red is it's right here.
Please.
Like, you don't, you've always liked it before, and I was like, yeah. well,
You
that's-
know,
I'm sorry.
to sleep.
I'm sorry.
Honestly, I thought he was gonna be like.
You're like, something really hurts.
I thought he did.
It's like straight, like, no, you're something really feels right.
No, when I called for us to walk to the room and was
Go,
like,
it's just like you're getting.
help, and he was talking with me, I
Just
went.
gonna keep getting color.
I was like,
And he just didn't say anything?
well, I mean, the patient was like,
Oh.
he literally got
Sounds like, hold on, patient.
And then he said something like, I wish that man had like punched me so I didn't have to work on New Year's. Yeah.
Oh.
Uh-huh.
This guy. I don't know if I
Yeah.
can relate. Oh my gosh,
you
I
ask
still have my phone on him.
Did you ask him what he was doing for New Year's?
Yeah.
You're like,
We don't even say.
not that kind of stuff.
For some reason, he told me normal. And he'll talk to me when we're alone. Yeah. So weird. Some people say.
What is that?
Because he knows I'm like.
I made it up. Sometimes I've been trying to.
Oh, he's trying to play.
He
cool,
feels
too.
flattered about it. He told someone that.
Yeah.
She was like, how do you feel about it? You know that, and he was like, and then he's like,
So my guys, like, it's not.
I feel man, and he's like,
But, yeah.
what he said, but
I mean, 10 years. But
Yeah.
really, too
Oh,
much.
I don't think, I think it's like.
You think you would date a girl from your yard?
Well, depends.
Like,
No, really doesn't depend. Like if I'm
it's like 10 a day or 10 a
Because like sometimes,
the person.
yeah, like
Yeah.
age doesn't. Some people are much more mature.
Yeah.
I'm a little immature though. But that doesn't mean I don't have room for growth. You know what I mean?
But like I said, like sometimes. It's like,
Are you saying I should just leave? Maybe that's when it might be a better time.
Also, like, from coming from like a professional. You should pursue it. Mature work.
Wow, I need to know.
Like,
It's
not-
rough because.
It's hard.
Uh-huh.
It's, like, you know what I mean, but like, someone's gotta leave. If we all have like, someone's gotta
I've
leave or
seen
something.
bad stuff.
Or someone's gotta switch forward.
Yeah. But then there's always talk and drama.
100%. You bring baggage to whatever floor everybody else.
I don't work, it's somebody says like.
He's dated a coworker in the past.
So it went bad, that's why he's leaving.
Yeah, that's why I.
Okay.
But she was probably a nurse.
Hold on.
Probably a nurse. I'm a CNA.
I'm gonna hold my pen.
And I'm
Probably loves some younger girls who
You should see.
He tells all his friends, I'm sure.
Okay.
Like, yeah, I got this young girl.
Yeah. What did it say? Someone called him. So then he was like, but my only admirer is a young little girl.
That was a good brag.
I know, when that person told me, when that person told me, I was like, whoa, he's probably, I guess. He felt that good about it. And then I was like, what's wrong with that? There's nobody else in the office.
Nope.
There's just- Cause I was like, that just sounds like me. A young little girl. You should see what he likes.
Huh?
You know what guys, you know, they like their pictures.
You can-
Sometimes I don't get it. I'm like, that's your color. It's what you like. And then you're like, you know, you're like.
Oh, you're.
Wait, what? They like. Nobody laughed.
Like,
Okay,
I mean, true. You can look at my Instagram.
because it's flat.
So,
I would be kind of. It would be like, am I not enough? Plus.
I haven't got a-
it's like almost everything.
You should call me.
But, yeah.
But like,
Probably not like everything, like, you know, like,
I wonder why the finger just goes on a random girl, like who they'll never meet. I don't do that. Just a random guy. Like, that was. And then my family could see it. What if they see that Ken
oh, you're,
was
like,
cat, like,
before Instagram,
absolute
before Instagram,
what's this?
I used to get a like feed. You could see what people.
I
like.
wish they still had that.
That is, I know, like.
I love that.
Back in the day, people would get that. I was like, why would y'all? That's not. That's a terrible thing. They're like liking stuff, you're like, oh, but they're like, you got like dirt on them. Oh, for sure.
At that time, they would be like, okay, I'm gonna like this to seem intellectual, and then I'll like this to appear like I like a fake. You know, well, some stuff, or you would try to do stuff with like.
Or if they're or if they're in a facility.
They,
I would do like.
I don't know.
I feel like they would have like a.
I'm just on, that one, I'm just on pure afraid.
But they're leaving it,
That one, like, if I start doing that, then I have to get no.
Okay, let's go ahead and get back into it.
Those are good.
like that.
This one, like,
So if you got kicked out of the Menti, you can get back in by just going back to Menti and you can enter this code here if you are out. I don't have the QR up anymore. So now that we've talked about infections, we're gonna change paths a little bit and talk about obstruction. So when we have obstructed urine flow, that just means that somewhere in this tract, something's blocking. It can be either complete or partial, meaning that it might just be partially obstructing, right? We think about men with prostates. We keep using that as an example, but you're gonna see men with prostate issues common. So that's usually a partial blockage where it's making it more difficult. Anytime you do have some sort of obstruction, it's always significant, right? It's always a big deal because that means that urine is backing back up. It can be unilateral or bilateral, specifically when we're talking about above the bladder, right? We can have below the bladder or some sort of urine outlet obstruction, but anytime we're above the bladder, it might be just one side or another, depending on what's causing the blockage. When I say blockage or obstruction, those are like the same thing, right? It means the same thing. Something's keeping the urine from flowing down the path it normally would. It can develop rapidly or slowly, and just depends what's causing it. That backwards pressure is significant though, because, right, usually the pressure or the flow, it's going down. It's going from the kidneys down the ureters to the bladder and out. Backwards pressure means that something's blocking somewhere and the pressure is backing up. That's what it means by backwards pressure. It can lead to damage in the kidneys. It can actually hurt the kidneys by having that backwards pressure. And eventually it could lead to chronic kidney disease. So that's part of why it's such a big deal, because we don't want to damage the kidneys from having that backwards pressure. It can also cause kidney distension or ureter distension. And what that means is that when you have this fluid, right, the kidneys are kind of big filters, right? Blood flows through the kidneys and any extra water or fluid gets sent down to the bladder. Extra electrolytes or waste products, those are all filtered out and sent down. If everything's getting backed up, the kidneys actually get swollen. So you can see on x-rays and CT scans, the kidneys are like bigger than usual. They're swollen. Sometimes if there's a blockage in the ureter, instead of having these nice little thin tubes, maybe there's a stone in that ureter blocking. You can see above that stone, the ureter gets swollen. All that pressure of the kidney trying to send fluid through can't go through and it gets swollen. So the swelling of the kidney is called hydronephrosis. So if we're doing our word building, hydro is water, right? Or oftentimes we call it like swelling, usually with hydro, and nephrosis, kidney. We know that. Ureters, when the ureters are swollen, what do you think that's called? Hydro, right? Hydroureter. Just like hydronephrosis, it's hydroureter when the ureters are swollen. I might have pictures of this. Maybe they're not here yet. All right, so let's go from the bottom. So if we talk about urethral strictures, that's where that urethral lumen is narrowed. It might be scarred. Like I think of our patients who have surgery in their urethra or a lot of bladder surgeries, or maybe they are somebody who has to be straight cast every few hours because of some issue. You can get scarring that happens. That scarring can narrow that urethra, make it difficult to get the urine out. It could be injury. Sometimes STDs can cause scarring that can cause issue. Enlarged prostate. Men are greater than women at having these issues. I think it's because of the prostate, because the prostate usually causes a lot of those issues. Signs and symptoms. What are we going to see with patients to have this ureter or urethral obstruction? Diminished urinary stream, right? So normally, if your patient pees and they have like a good amount that comes out, but now it's just kind of dribbling, or it's a really weak stream. That's a diminished urinary stream. They might have dysuria frequency. They might get UTIs because that urine's backed up, right? It's that pond analogy. It's kind of sitting there. It's able to grow more things in it. Treatment. Well, if the bladder is full, we want to empty it, right? So it might be catheterization. We might have to do a urethral dilation. And when I say we, I mean the treatment team, not us, right? We aren't going to be touching any of that. But a doctor or provider who's been trained might go in with a type of catheter with a special balloon, and essentially they would dilate or try to open up the urethra. Especially if it's caused from scarring, they might try to break up some of that scar tissue to allow flow through the urethra. Do endoscopic urethrotomy. Word building again, otomy is some sort of opening, an incision, usually opening up. So they might go in and actually try to open up that urethra. Urethroplasty, or even like a stent, right? They might go in and put a stent in that will kind of expand and help keep that urethra open. Bum, bum, bum. Okay, now we're going to go into stones. So if I say nephrolithiasis, go ahead and vote. Are we talking about kidney stones or ureter stones? All right. Either you all knew or you're really good at voting what other people vote. Or you're really good at doing word building, right? Because we learned that nephro is kidney, right? Nephro is kidneys. So nephrolithiasis, those are like when your body is built stones. That's where stones have built up in your system. So we also might call them renal calculi. That's another word you might see. They're hard, small stones in the urinary tract. They can be caused from a variety of different things. I think your book calls them urinary salts. When they say salts, it doesn't mean sodium chloride as like table salt. It just means your excess, like minerals or things that have built up in your system. And we'll talk about what they're caused from in just a minute. So nephrolithiasis, kidney stones. Ureterolithiasis, that's a hard one, is ureter stones, right? And so when we think about where they're at, sometimes it's nice to see pictures. Okay, this is another one of those videos. This one's really short. It's like 90 seconds, I think. Okay, that Do they? I mean, I know way more about human anatomy than I know. Is that what it's called? Okay, so this picture kind of shows you as well. Oh, good, and this shows the hydroureter. So this shows you where you can have, like, you can have stones in the urethra. Typically, they don't form there. They can, right? The video is right. They can form there, but typically in the ureter or your ureter, the urethral stone, they will travel there, is how they most likely would get there. Like the video said, usually they form in the kidney themselves, and then they're able to be expelled most of the time and will travel down the ureter and then into the bladder. The issue is when it blocks, right? A lot of times people will get kidney stones and they'll pass them, they'll go through. Sometimes people don't even know that they're passing a kidney stone. Sometimes they're more big, they're painful, they know it hurts. The issue is when it starts blocking. So here you can see this urethral stone and see how this ureter is so much bigger than this one. That's what that hydroureter looks like. Oh gosh. If you ever want to do a fun Google image search of hydroureter and hydronephrosis, some of those images are pretty amazing on how big those ureters and kidneys get. They really do hold, like they get so swollen. Sometimes you might see something called a staghorn stone, and that's where you get these stones that have, like a stag is another word for like a elk or deer, and they have those, antlers, you know? And so when the stone is shaped more with like, it's not smooth, these kidney stones are usually smooth, but they're usually more roundish. When they have like these big horns, these big protrusions, often into the kidney itself, those are called staghorn. There have been patients who I've cared for when they have these giant staghorn kidney stones, they can't actually take care of them. I've seen patients who have had to have a nephrectomy because of that. So let's use word building. Neph is kidney. What is ectomy? Removal. Yeah, they've had to have their kidney removed because of the staghorn. Now this is a rather smallish staghorn. I've seen them really big as well. Okay, so pathophysiology. So physiology is how something works, right? Pathophysiology is the dysfunction. How does this dysfunction work? So like the video said, there's these urinary salts, minerals of some sort that kind of settle out. They form these crystals, and then they form into these calculi, these stones in any one of these spaces. Usually the stones that are less than 5 millimeters, and I'm not going to test you on size, but just know if they're real small, usually people can pass them pretty easily. If they're bigger than that, they're much more likely to get stuck. And they're painful and they require treatment because they're obstructing, right? Anytime there's obstruction, that's we need to do something about it. So etiology means how does it happen? Like what's the path, like why is somebody more at risk of having this, or what about them makes them at risk? So hereditary, some people, right, just like your parents have blood pressure, so you're more likely to have high blood pressure. Did I say that right? I don't say that right. If your parents have high blood pressure, you're more likely to have high blood pressure. Everybody has blood pressure. If your parents have kidney stones, you might be more likely to have kidney stones. It might just be part of your DNA, your genetic makeup. Chronically dehydrated, right? I talked about that urine concentration, the higher concentration of urinary salts. So if you're more dehydrated, your blood, your urine, everything is going to be more concentrated because of dehydration. Also, we've correlated diets that are really high in sodium, sugar, and protein are more likely to form kidney stones. If you're obese, or if you tend to have infections, specifically UTIs, you are also more likely to have these stones form. So just like our risk factors for urinary tract infections, we want to know what are the risk factors for somebody having stones. Also, unfortunately, men are at greater risk than women. I'm not sure why. My hypothesis is that women are better at drinking fluids. I don't know that. That's just what I think. So, as I drink my coffee, which is probably not great. Also, I don't know if we talked about this when we talked about incontinence and urgency, but speaking of drinking coffee, what caffeine is in coffee? What does that cause to your bladder? It can be a diuretic and it's a stimulant. So if you have somebody who has urgency or frequency, that caffeine actually is stimulating and irritating your bladder. So if somebody has a UTI and they're like, I can't drink my coffee, I just pee all the time after that. And you're like, well, yeah, because the caffeine, right? It's making you feel like you have to go more. All right, let's move on. Okay, so signs and symptoms. So there's a couple of different signs and symptoms depending on where the stone is at, right? So if we have nephrolithiasis, which is in the kidneys, you're usually going to have that costovertebral pain. Remember that if you go back up, the costovertebral angle pain. You also are probably going to have hematuria. Yeah, blood in the urine, exactly, right? Because that infection, that stone is kind of implanted in the kidney with the inflammation, it's causing probably a little bit of bleeding. And so you'll see that in the blood. Now, you probably won't see frank blood. Have you guys heard that term before? Frank blood? Yeah, that's like bright red blood. Like if somebody was just bleeding or urinating blood, that would be like frank blood. Always make sure if we have somebody, a woman of childbearing age, we also want to make sure that she's not in her menstrual cycle too, right? That's also something I didn't mention earlier, but when we talk about our data collection for the urinary system, when we're collecting urine, a urine specimen, if a woman is on her menstrual cycle, we probably aren't going to get a super valid result, right? Because we most likely are going to get some contamination from that menstrual flow. So something to keep watch on. I mean, if somebody, yeah, good question. It might be if you have a tampon or a cup or something like that. There can still be leakage or other things occasionally. So I would say you could go off of a general result, but I wouldn't take it. I want to repeat after they were off of their cycle, if that makes sense.
Better maybe just do it
Like a cath. Oh, it depends on the situation. Typically, the risk of infection goes up so much. Anytime you catheterize something, we try to avoid that at all costs. I know, it's complex. Okay, sorry, I got on a sidetrack, but I just want to make sure we're thinking critically, right? We're thinking through those things that we are aware, right? Because we don't want to go call the doctor and say there's frank blood in the urine. And he's like, well, she told me she was menstruating earlier. So, like we're going to think through these things before we make these phone calls. Not that I've ever done that before. So when we move to the ureterolithiasis, which that's a stone in the ureter and the tubes, what you usually see is you have pain on the flank, not necessarily the costovertebral angle, more of like flank, one side or the other. And like I said before, with stone in the kidney, it's going to be the costovertebral angle on the side where you have the stone, right? So if you have a right-sided kidney stone, you're probably going to have right-sided costovertebral angle pain. If you have a right-sided ureter stone, it's probably going to be flank pain on that side. Now there might be people that have bilateral stones. So they might have bilateral pain. That stinks, but it happens. But they usually have pain with it when it's in the ureter. That pain tends to radiate down to the genitalia. There's something about like, I think you guys talked about pain last term in MedSurg 1 a bit. Sometimes when we have pain in some of our organs, we feel it at different parts of our body. A really common example is when somebody has a heart attack, right? Oftentimes they say like radiating up your left side, down your left arm. Those are kind of classic signs of if you're having cardiac pain, cardiac issues. With our kidneys, oftentimes, it's flank pain, costovertebral pain. When it's in the ureters, oftentimes it radiates down. That's a sign that it's in the ureters. So with these guys, they get this intense urge to void. Their body is telling them, get this out. I have a blockage. They feel like they need to pee. So oftentimes they're like, I feel like I need to pee, but I don't have anything left, or they're not able to pass anything. They have a lot of frequency, right? They're trying to pee a lot. It's painful. They might have bleeding in there. Same thing. They might have the inflammation that's causing the bleeding. And specifically when the stones are in the ureters, they get nausea and vomiting. So if you have somebody who has a kidney stone, right, it's up in the kidney, and they travel, right? Sometimes it'll move from the kidney down into the ureter, and maybe their pain goes from being up in the costovertebral area, and they're like, man, it kind of is lower. I feel like I have to pee all the time, and they start getting nauseous and vomiting, in my mind, I'm gonna say, I think that stone has probably moved down into the ureter because their symptoms have changed, and that more associates with the ureterolithiasis. Sorry, I know I don't say that word very well. This is a safe place to not pronounce a word very well. We're all practicing together. If you have a bladder stone, usually it doesn't really affect patients too much. They might have a little bit of bleeding if that stone is kind of causing some inflammation. The reason they'd have a lot of symptoms, which would be oliguria, which, what does oliguria mean? Yeah, no urine. There's nothing being produced, is if that stone blocks the ureter. Otherwise, they're not going to have many issues. So sometimes you might see a CT scan or an X-ray report, and it will say multiple bladder stones. But as long as those stones aren't blocking anything, they might not do anything about them because they're not causing a problem at that time. That makes sense? Okay. What's next? Okay, so prevention. How do we prevent them? If we've identified the patients who are more at risk, what are we going to do? Well, we're going to make sure they're really well hydrated because we know if their urine is more concentrated, it's more likely to build a stone. We're going to talk about diet. What are the things that we want to try to reduce with these guys? Sodium, sugar, and proteins. Yes, I was like, I know you guys said it over there. My brain wouldn't connect it. Good job. And then exercise. Patients who have more exercise or who are more active tend to produce those stones less. So, or if they're producing the stones, activity helps move things through. It helps to move those stones down. And I'd rather get those stones to move on down when they're small and they can fit through everything rather than having them build up larger. All right, so diagnostic tests. We've talked a bit about these already. Some blood tests that we're going to do. We want to check their calcium, uric acid, blood urea nitrogen, BUN, and creatinine. We're gonna, oh goodness. We're gonna talk more about these labs next week. BUN does tell us a lot about the kidney function, but the BUN can be variable. The level might be elevated or low based on things that are other than the kidneys. So BUN has good information, but it's not always exact or not always the same just about the kidneys. The creatinine is more exact. The creatinine will tell us more specifically about the kidneys, meaning if you are dehydrated, you're going to have a higher blood urea nitrogen because of the dehydration. It's going to be more concentrated. But your creatinine, that's a waste product that your body builds up. And just so everybody knows, creatinine is different than creatine. A lot of like bodybuilders and people, like they want to like, I think it's, they put creatine in their smoothies. Yeah. I don't know what that is. I probably should look it up. It's different than creatinine. That's it's some sort of nutrition, the creatine. Creatinine, that's a waste product that our kidneys filter out. Unlike the blood urea nitrogen, our kidneys don't want to keep any of that in our system. They want to get rid of it all. So even if you're dehydrated, your body is naturally going to get rid of all of that creatinine. It's only if the kidneys are damaged that they're going to be retaining some of that creatinine, and you'll see that level go up. So does that make sense how sometimes the BUN might be elevated, but it's not because of kidney issues, it's because of dehydration, whereas if the creatinine is elevated, it almost always is pointing specifically to kidneys. So creatinine, that's our gold standard, like our marker when we're looking at kidney function. Urinalysis, right? We want to look at hematuria, the crystals, urine pH. Maybe we'll look for those casts, like we saw in the video, the white blood cell casts. It says 2 24-hour urine collection. That's your book. I haven't seen it in real life. They might do a 24-hour urine, but I haven't seen 2 of them for this. You might get a CT scan, a renal ultrasound, abdominal x-ray, or IV pylogram. Anybody know what a pylogram is? What's pylo? Pylo also refers to kidney, just like nephro. And then the gram, that's usually when we're talking about some sort of IV contrast study. So it's usually associated with something like a CT scan. Well, they'll do a CT scan but they'll also do with a pylorogram, an angiogram, which would be like your blood vessels, somewhere where they inject contrast dye into your system and they look to see how that contrast goes through your system. You can see how that'd be really helpful. Like if this is our patient here, and let's say they have a big stone in the middle, hope we all can kind of see this. If they have a stone over here on this side and we do a pylorogram, we're gonna see that contrast dye and it will come through and then it will flow. And on this side, on the right side, it's gonna flow down to the bladder. But on the left side, we're gonna see that dye flow down here and stop because it's stopped by that, the stone. So the pylorograms are really helpful at seeing things. We also do that when we think there might be a blockage in a blood vessel, right? That's where we might do the angiogram or, you know, like look to see the blood flow. One thing to know about grams, angiogram, pylorogram, things like that, is that that contrast dye can be pretty hard on the kidneys. Like we talked about the gentamicin being nephrotoxic, it can be really hard on the kidneys. That kidney contrast dye can be really nephrotoxic as well. I know, what do you do? Yeah, so you look at your patients and you have to decide with their creatinine, you look at their BUN as well. Sometimes we'll look at their GFR, and that's the glomerular filtration rate. And that's different numbers based on age, genders, ethnicities. But you look at all of those. Sometimes people are at high risk of having kidney issue, you know, from this, but they'll say, we really need to get it. So we're gonna give them maybe some IV hydration to help support them and help flush that out of their system. But that's something, whenever you see somebody that has some sort of CT scan with a contrast study, which is usually gonna be a gram of some point, you wanna make sure we know what their BUN and creatinine are. Wanna make sure that we're not gonna injure their knees. Okay, I get sidetracked real easy. Okay, so therapeutic interventions, what do? If it's a small stone, you wanna just let it pass, right? So we keep them hydrated, so they have more fluid, keep things going. We give them some analgesics. Alpha blocker, that actually helps with vasodilation, right? Helps with dilation of things. And so that might help the stone to pass a little bit easier. If the stone is large, it's blocking, it's causing a lot of symptoms, that's when we're probably gonna go with IV hydration. Higher pain control, you know, they might look at more IV pain medicine rather than oral pain medicine. They might do some diuretics to help push fluids down the system. Maybe some allopurinol that might help to reduce some of the renal salts that are there. Or maybe even lithotripsy, and that's a procedure. You got a picture? This is a weird picture, but it kind of shows it's surgery where you have somebody in a surgical suite, and essentially it's like using sound waves to break up those stones that are there. Now, sometimes they can't get them with the stones, and I don't know if they have it here. Yeah, so sometimes they actually have to go in with surgery and do a cystoscopy. And so remember, cyst is what your organ? The bladder, yep, and oscopy is it's a scope, right? So they go in kind of like with a catheter, like you guys do for Foley's, but it's bigger. A lot of times they have a camera on them. And so they go in with that scope to try to see if it's in the bladder. Oftentimes that catheter can go all the way up onto one side or the other. And sometimes they can go and kind of break up that stone that's there. Sometimes they have to do actual like lithotomy and surgery and open up that stone. Sometimes they have to do what's called a percutaneous nephrolithotomy. Actually, we're just gonna call them nephrostomy tube. That's way easier. So nephrostomy tubes, that's when you have hydronephrosis, which is swelling of where? The kidneys, right? Swelling is too much. That extra swelling, that backwards pressure, like we talked about, that could damage the kidneys. We don't want to let that go on for too long because you kidney damage. So they put in, I know I put it in here. Okay, we got to get back to it a little bit. I know it's here somewhere. But when we talk about the nephrostomy tube, I'll show you the pictures. It'll make more sense. Okay, pin in that, we're going to move on. So complications. If you have a kidney stone, what are complications we might see with patients with that? Well, they might develop a UTI. They might get hydroureter or hydronephrosis. They might even get shock or septic from having, usually it's pretty severe, like they have the hydroureter or hydronephrosis, it's built up pretty bad. Sometimes if it's damaged the kidney enough, it can cause chronic kidney disease. Nursing diagnoses for these patients are gonna have acute pain. They're gonna have risk for infection, and they might have a knowledge deficit, right? Maybe they just eat like the Atkins diet or something that's really high in protein, even though they've had kidney stones in the past. If we want to educate them, you might want to decrease some of that protein. Data collection. You guys know all of this, I'm sure, but straining the urine. Has anybody strained a urine for a stone? I did it first when I was a CNA, and I remember I found a stone one time, and it was like I won the lottery. I was just like, oh my goodness, there's actually a stone. It was very exciting. But it's really important because if they pass those stones, we want, first of all, we want to know they passed it. And usually the patient will say, they'll be like, it doesn't hurt anymore. You know, they're like, wow. I mean, they'll tell you, like, usually these stones, if they're big enough, they really hurt. And they can tell you right where it hurts. And I mean, it's very painful. But if they pass those stones, we actually want to send them to the lab, and we're going to test them to see what they are made of, right? Because that's going to help us tell our patients, hey, this stone had a lot of sodium in it, right? You probably really need to decrease the amount of sodium in your diet. You know, we want to work with them. Okay, question for you. If you have somebody you're taking care of a patient with renal calculi, renal stone, what are essential when you're taking care of these patients? So select all that apply. What do we want to do with these guys? And we're going to say it's a significant calculi. It's a pretty big one. Can you select more than one?
No.
Okay. Sometimes when I reset these, it resets it so you can only select one, and I have to go back and manually choose that.
Yes. Yes.
Right, yeah, you have to prioritize. I didn't put these in like an order of like, you know, which to go first. Okay, let's see what our answers are. All right, so correct. We want to strain the urine. We want to provide pain relief, and we want to maintain hydration. We definitely don't want to limit fluids, right? That's going to make them more dehydrated. We don't want bed rest because we want them moving. What's the moving going to do? It's going to help it, hopefully help the stone to travel and move on. That's our goal, right? Our goal isn't to have to go in and do surgery. Our goal is if it can move through the system, we want to do everything we can to have it naturally move through the system so they can void it out. That's going to be the best thing for them. So they don't actually have to have anything invasive happen. All right, moving on. So we talked about this already. So hydronephrosis, we talked about this a little bit. This is where the nephrostomy tube is at. All right, so we talked about the urine backs up, enlarges the kidney, gets swollen, causes pressure, could cause damage. So we want to treat the cause of it. This picture is kind of interesting because it shows kind of normal. We have a normal kidney, ureter, bladder. Here, you've got where it's kind of starting to get swollen. And here you've got some pretty massive hydroureter and hydronephrosis. We talked kind of about the signs and symptoms. They're really similar to a lot of the general signs and symptoms that we're having, but we want to treat the cause. So if it's like, and the cause is going to be different and the treatment's going to be different. So if the cause is a ureter obstruction, right? Somebody has a prostate that is enlarged and causing stricture, we're going to put a catheter in, right? We're going to drain the bladder. If it's a stone that's causing obstruction, we probably need to go and treat that stone to relieve the pressure that's in there. They might go ahead and do stents in the ureters to try to keep open that area. Especially they can do that when they do like a cystoscopy and go up with the catheter. The nephrostomy tube. Sometimes if they can't do the surgery right away and it's urgent, they want to relieve that backwards pressure that the kidney's under. So they put in this tube that will drain the fluid out of the kidney. What do you think that fluid looks like?
Cloudy, mucus, dark, yellow.
It just depends. It usually just looks like urine. right? Because it's the fluid that the kidney is kind of trying to strain out and it can't, it's backed up. So usually that fluid that's in there is gonna look, I mean, if they're infected, it might be cloudy, it might be other things, but it just looks like urine. So here, what you can kind of see, this is the kidney. And so this is a tube that's coming from the outside into the kidney, and it has a coil in here. Those coils, this coil through here, there's openings all through here. And that pressure on there allows extra fluid that's backed up to travel from those openings out into this bag. In a real patient, what you're gonna see is probably gonna look something like this. It's gonna be bandaged up because we really don't want it to get cold or like, mess with very much. Once it's in, it's in. Usually they're sutured in or they have some sort of thing that kind of keeps them in. It's not just gonna fall out. But we also want to make sure with these dressings are kind of more specific because if it gets kinked at all, that fluid's not gonna be able to come out. So we want to make sure it keeps like open. So let's say somebody has a nephrostomy tube. They've got, what side is that? Oh,
The right side.
is the right side? Okay, let's say they have a right-sided kidney stone, it's totally blocking up, and they have a nephrostomy tube on that right side. Are they still gonna void? Yeah, why will they void? Right, because they have two kidneys, right? They have the left side that's still gonna be making urine. Really important with these guys, we want to make sure we're managing or like recording their intake and output. And we want to really make sure that we say, this is how much they're voiding. And this is how much is coming out through this nephrostomy tube. So really important we differentiate between that. And a lot of us, anybody work as a CNA right now? Yeah, when I worked as a CNA, there were so many things I didn't understand. If my nurse said, hey, I need you to make sure you say the difference between the nephrostomy tube and the urine, I'd be like, I'm working, right? But as a nurse, I understand why. I understand that I'm actually seeing how much is the nephrostomy tube is showing me how much pressure, that backward pressure, and it's pushing out. It's letting me know, is that still blocked up? Because if it's not blocked anymore, if that stone moves, that nephrostomy tube probably won't clog. It's all going to bring down like it should. So I get really good information by keeping those two separate. As a nursing assistant, I might not understand that as well. So I think it's really important as part of the healthcare team that we help our team understand the why, right? Because if I just say, hey, make sure to do this, people are probably less likely to do it, right? But if you say, hey, it's so important that I know which kidney, or that we know which kidney is actually this output is coming from, and to do that, this is what we need to do. It can be just as simple as a few sentences, but I think that helps to pull everybody in and gives them knowledge, right? Like I've had so many times where my CNAs have been instrumental to updating me with the patient status because they know so much, and so we all want to share with our knowledge and share like taking care of a patient. So anyway, the why is important. Okay, now we're moving on. Just so you guys, I forget, I haven't had you guys actually in class yet. So my husband and I have been married a very long time. I think it's 25 years. I don't know, a long time. And what I found is that he doesn't keep up with me sometimes. Like I'll be talking about something and I've moved on and then moved on again and he's still back with this conversation. So every time that I change topics, I clap. And so then he knows that I've moved on to something else. So I kind of do that in class sometimes. So if we're done talking about stones, we're now going to talk about cancer. Okay, so we're different topic. Feel free to use that with your loved ones. I found it very effective. Okay, so talking about cancer. It's the most common of the urinary tract cancer, which is cancer of the bladder. So we're looking at kidneys, bladder, all that. Bladder is most common. It occurs, again, more in men than women. Sorry, guys. And usually it's in patients who are 50 to 70, right? They're a bit older. So the etiology, where does it come from? You're going to see this in most cancers, you guys. Smoking and pollution. Those are the things that are going to put people at the highest risk of having cancers, almost any type of cancer. That's what causes patients to be more at risk. So important that we talk to our patients who smoke about strategies to quit, because we know that it puts them at risk for so many more things. So signs and symptoms. There's usually not too many in the early stages. Usually what we find is in the later stages, they start having signs that are similar to a urinary tract infection. They start having a little bit of pain, a little bit of dysuria. They might have a little bit of like hematuria, blood in the urine. They might have a difficulty time peeing, especially if there's like a blockage, like a tumor that's blocking. Diagnostic tests, usually when by the time they figure out what's going on, because it has such few symptoms early in the cancer, it's usually rather advanced by the time we figure it out. So they'll go in with a cystoscopy and they'll do a biopsy. They'll look for blood in the urine. They also do tumor markers. So for most types of cancers, we have tumor markers. They're essentially little flags in our blood that just say, hey, I'm here. So with bladder cancer, there's different types of markers that we might see. I'm not going to test you on those. It's just nice to know. If you're out in clinical and you see, wow, this patient had, this BTA, the bladder tumor associated antigen, and that was pretty elevated. That might tell you, oh, does he have bladder cancer? What were his numbers before? We're also going to do imaging. What does imaging mean? Yeah, it's usually any type of radiological study. So like you said, MRI, CT, X-ray, any of those things. We're going to do some imaging to try to figure out where the cancer is at. So therapeutic interventions, they might do intravesical therapy, like an IV therapy. So they might, essentially it means chemo usually, right? Chemo or immunotherapy. There might be photodynamic therapy. I haven't heard a lot of that around here, but it's about like using like certain types of light rays to help battle the cancer. And they might do surgery, right? Sometimes they go in and try to remove the tumor itself. They might do a cystectomy. They might have to remove the whole bladder. And sometimes if they do have to remove the bladder because of the cancer, they'll do what's called a urinary diversion, right? Because if we have this collecting balloon in the bladder and we have to take it out, we have to have somewhere now for that urine to go. So that's why we call it urinary diversion. We're diverting it, moving it somewhere else. There's a few different types of this. So sometimes we'll do a urostomy. Have you guys done urostomy and colostomy care and foundations? Yeah, so I think people are usually more common or more familiar with colostomies, and that's where you take part of the colon and you divert it out, and then you have a pouch where that colon will empty the stool into, right? Sometimes it'll be an ileostomy, which is where instead of going to the colon, it's higher up in the small bowel. And the ileostomies are usually a little more liquid because the colon is what kind of absorbs a lot of that liquid. So we also could have a urostomy, and that's where urine is coming out. A lot of times they will create a ileal conduit, which means they take part of the ileum, part of the small bowel, and they form it into a pouch, kind of like what our bladder is. And then they form a little duct that will, so the urine will go from our ureters into this new little pouch and then come out to be like an ileostomy. So somebody talked about mucus in the urine.
I was just gonna say, actually, that's what I was thinking of, the ileal conduit.
Yes.
Mucusy, cloudy.
Yes, exactly, because it's the bowel, right? And our bowel secretes mucus to act as a lubricant for our stool. Even though our sweet little new pouch that we have for a little mini like pseudo bladder, even though now it's just for urine, it doesn't know it. It still thinks that it's there for stool. And so it's going to keep secreting some of that mucus. So somebody with an ileostomy, they're going to have urine that will come out that will look like urine, but they might have mucus as well. And that's normal because of that stool, the pouch that it is. So here you can kind of see where this looks like a whoopee cushion to me, but this is what I found. So here's where you have this new little pouch they've made, and here's where the stoma is. And just like with a colostomy or an ileostomy, you're going to have a device on there with a pouch. And so that patient has to learn how to take care of that, right? They need to look at their skin. They probably want a wound care nurse to come look at them. They also have some continent urinary diversions. So that's called an incontinent urinary diversion because the urine, oh, good Lord. This one is incontinent because as it fills up, it's just gonna empty out. It's incontinent. They also can create some continent urinary diversions, which you can have like essentially an opening, but there's essentially a valve there. They can create a valve so that patients know they have to go in and catheterize through their abdomen and essentially empty out that bladder. But that way they don't have to wear a device or anything on there. This is usually called an Indiana pouch. Is that right? Yeah. They have to, but this is lifelong. They have to catheterize themselves through that opening. There's also, they can make an orthotopic neobladder. That's most common. It was really fun last term. We had somebody that was learning about this and then they got to see it in the clinical setting. And so that was really interesting to be able to correlate specifically seeing a patient with that and learning about it. But they, just like with creating that new bladder from the intestine, they do that, but then they connect it to the ureters and the urethra. So all those other structures work the same. It's just they've made a new bladder out of that bowel tissue. And that allows them to void through the urethra like they normally would. So they get to control when they pee. That's why it's more common now. It's a little more complicated, I think, but it allows people to void like they normally would. It gives them more of a normal life. And so you're going to see this more than you would some of those other ones. Yeah.
Catheterize themselves and they forget or they don't do it or something.
Yeah, so probably similar to like the overflow incontinence is that it will fill up and that valve essentially will probably fail. And they might have some incontinence or if they might have some hydronephrosis and where that urine is getting backed up. Yeah, it's a good question. It has to go somewhere. We talked about this. That's just another picture. Okay, so cancer, we talked about maybe having a wound care nurse, right? We want to talk about pre and post-op care with them. You guys have gone over pre and post-op care in MedSurg 1. So some of the big things with pre and post-op care, make sure we have consents for the patient. They told that they understand. Like, what's the nurse's responsibility for the consent? Do you guys know? Like if a nurse is having to sign it, it's called witnessing it. And when we witness it, what is our responsibility to that? Well, it's that their patient is with it, but the patient understands, right? Because sometimes I've seen where doctor's office will send over a consent and they'll have filled it all out. And I'll ask the patient, and they'll go, well, I actually haven't seen the doctor yet. And I'm like, oh, well, we need to for sure make sure I'm not going to sign anything until I know that you've talked to the doctor. You understand this, our responsibility by witnessing it is that the patient understands the procedure. They've agreed to it and that they have signed it. So we do not have the responsibility of having to explain the procedures to them. We might want to talk to them about body image coping. I think one of our groups talked about support groups. This might be another thing where maybe try to connect people that maybe have similar experiences, especially if they have the ileal conduit or, things where it's just a different way of living. And we also want to teach them, especially if they have that pouch, how do they take care of their skin? How do they know what to look for if the skin is infected? Sometimes you'll see that there'll be cancers, not only of the bladder, which is more common, but you could have cancers of the kidney. It's usually after age 55. So kind of like the cancer of the bladder, it's when you're a little bit older. Not going to say 50 is old, just older than younger. Men, again, twice the incidence as women. So men are just going to be the more likely candidates to have urinary issues. Risk factors, again, smoking, obesity, high blood pressure, long-term dialysis, the strain that puts on the kidneys, or just the kidney dysfunction in general. And then again, industrial pollution, just like all of our cancers. With the signs and symptoms, just like the bladder cancer, we don't see a lot of symptoms until it's usually later stage, and it mimics a urinary tract infection or even a kidney stone. And so that's why we really have to try to make sure we're getting these guys diagnosed appropriately. with the kidneys, it's often diagnosed after it's metastasized. What does metastasize mean? It's spread, right? And unfortunately, a lot of times when cancer is metastasized, we see issues with the metastasized area. That's the one that's causing more problems. And then we're like, oh, but that came from the kidney, from the bladder. So when you have cancer of the kidney, our tests that we're going to do are very similar to what we talked about already with our stones, right? We might do an IV pylogram. What is the pylogram? Contrast to the kidneys. What do we want to make sure we look at before we do one of these? Not allergic, but really in kidney function. And what's the lab value we look at? Creatinine. Yes. You guys are so good. I'm so proud of you. All right. So therapeutic interventions. If you have cancer of the kidney, they might have to do a radical nephrectomy. What would that be?
They take the kidney out.
Yeah, total removal. Fortunately, we have two kidneys. You can function with one. You know, we prefer to have two, but one can work, right? They also could do a nephron sparing surgery, meaning they might try to take out the tumor of the kidney and spare as many nephrons as they can. Nephron's the functional unit of the kidney. That's the one that's really the worker bee doing the job of like filtering. So they might try to just take out the tumor and spare as many nephrons if they can. Again, radiation, immunotherapy, chemotherapy, you're going to see those for most cancers as treatments. Nursing care, one of the big things, especially with a nephrectomy, removing the kidney, think about where the kidneys are, right? They're kind of flanked a little bit higher up. One of the big risk factors you have if you have a nephrectomy is a pneumothorax. We're going to talk about that more when we talk about pulmonary, but let's do word building. Pneumo is air, usually relates to lungs. What about thorax?
You're in the plural space.
Yeah, did I already say that?
No.
Oh, good job. But yeah, it's where you get air in the pleural space. So if they're doing surgery in this area, they sometimes, not usually, but it's a higher risk of nicking or opening up a hole in your diaphragm. And that will allow air to go up into your chest cavity space and collapse your lung. So we want to make sure, especially if somebody has diminished breath sounds just on one side or the other, after this type of surgery, we're really looking at that. We want to make sure we're monitoring for any respiratory issues. So let's look at this. We're taking care of Miss McDuffie. She's 45 years old. She had a right nephrectomy, absent breath sounds on the surgical side. What action do you take? So turn to your neighbor next to you and just real briefly, you're taking care of Miss Duffy. What do you do? All right, let's see what F.A. Davis says. See how if it compares to what you guys said. It said notify the healthcare provider or the rapid response team. All right, good job. It said she may have a pneumothorax and requires emergency care. All right, I think this is kind of the end of this. I don't want to do the renal trauma. We'll get to that next week. Okay.
So she has diminished, so you've already like auscultated her lungs or whatnot, is that what that's saying? Or,
Sometimes they'll go in and it's a new patient to you. Maybe it's shift change. And the nurse reported she was, maybe diminished bilaterally or she was clear. And you go in and listen, and to you, one side sounds significantly more diminished than the other. Yeah, you want to definitely listen. All right, let's take a quick break. Because I want to do our last activity of group work. So, where are we at? Let me. All right, hold on one second.